Hi, I am Dr. Selvaraj, Professor of Surgery at Manipal University College, Malaysia. Welcome back to my series of surgical teaching video class. These are meant mainly for undergraduate medical students doing the surgical flux rotation and all surgical trainees as well. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. In this episode today, I am going to discuss one more operative surgery, that is surgery for anorectal abscess. So this surgery is, this anorectal abscess is a minor surgical emergency and has a recurrence rate of almost 25 to 50% because there is a need for further surgery and the damage to anal sphincter due to repeated surgery for this problem. Typically, two surgeries for this condition: a simple incision and drainage, or we can do incision and saucerization. So this is the classification for the perianal anorectal abscess. Here there are four types. Actually, the anorectal abscess at first forms in the intersphincteric space where there are glands. I mean, the perianal glands are there, the ducts of which are opening in the dentate line inside. So through this duct, okay, the fecal matter or the infection will go through the duct to the perianal glands, and these glands will get infected and will form the abscess in the intersphincteric space at first. And from here, this can gravitate down to the perianal region. This is perianal abscess, or it can migrate through the sphincter into the ischiorectal space, forming the ischiorectal abscess, or this can migrate above the levator ani, forming the supralevator abscess or pelvirectal abscess. So these are the four types: the ischiorectal and the perianal abscess. In both these types, we can see swelling from externally, whereas if it is intersphincteric abscess or pelvirectal abscess, we cannot see the swelling outside the skin, but the patients will have very severe perineal pain. So the same thing you are seeing here also. This is the first intersphincteric abscess, and this is the perianal subcutaneous perianal abscess, and this is the ischiorectal abscess. This is the supralevator abscess, and apart from these abscess, there is a submucosal abscess is also there here. So surgery for anorectal abscess, what is the indication? It is anorectal. If there are the two varieties, we have to do surgery. In the deep-seated abscess, usually we drain it under ultrasound or CT guided, either aspiration or tube drain. So indication is anorectal abscess. Anesthesia we can give either GA or spinal. Position is prone jackknife or lithotomy. We have to get informed consent after explaining all the risks of surgery. So injury to external anal sphincter will result in incontinence in 2% of the patients. This is accidental, and recurrence of this abscess or the anal fistula happens in 50% of the patients, where this abscess cavity has got a connection either to the rectal or anal canal, then definitely those patients will have will end up with, the perianal fistula. Pre-op preparation, you should do a distal rectal exam, proctoscopy to exclude Crohn's, TB, ulcerative colitis, or malignancy. Enema can be given on the day of surgery. So regarding the position, I told you can go either lithotomy or jackknife position. If it is a very small perianal abscess, you have to first see the area and confirm that this is perianal abscess, identify the abscess near the anal verge, and then make a linear incision over the point of maximum tenderness like this. So this is a small perianal abscess. You can do a radial incision like this. Yeah. And then we can drain the pus by Hilton's maneuver. That means you can put either your little finger inside or venous forceps inside and break open the loculi and make it as a single loculi and drain the pus. Then after drainage of the pus, you can curate the floor of this cavity and look for any opening that is leading into the either the rectal or anal canal. Presence of any fistula. Okay, and then you can lightly pack the wound with Operative soaked gauze piece here. When we are dealing with big perianal abscess or ischiorectal abscess, we can identify the abscess which is slightly away from the anal edge. Then we should make a cruciate incision over the point of maximum tenderness. After this cruciate incision, elevate 4 triangular skin flaps and then drain all the pus. And you can, if there are any, slough inside, wound debridement also can be done. And then we have to excise the 4 triangular skin flaps should be excised, and this is what is called saucerization. You have to excise all the 4 triangular skin flaps, and then again you have to curate the floor of this abscess cavity, that is ischiorectal abscess. Look for any internal fistula between this cavity to the rectal or anal canal. If there is any fistula, then this patient will definitely going to end up with perianal fistula. Then this is after excising the triangular skin flap, do wound debridement of excising any dead tissue, and then you have to curate, which I told you already. Then you can peg the wound loosely with Operative soaked gauze like this. So surgeries, as far as anorectal abscess is concerned, it is either incision and drainage for small perianal abscess, cruciate incision and saucerization for bigger perianal abscess and ischiorectal abscess. For deep-seated intersphincteric and pelvirectal or supralevator abscess, either ultrasound or CT guided needle aspiration or pigtail catheter drainage can be done. 50% of these surgical drainages are followed by fistula formation if these abscess cavities have internal connection or internal fistula to rectal or anal canal. So we have to determine whether these patients are having this internal connection. So first you have to examine the patient under anesthesia. Examination under anesthesia. Do a digital rectal examination. Palpate carefully for extent of induration to ascertain whether the abscess is perianal or ischiorectal. Then you have to use either Sims or Eisenhammer anal speculum to visualize the pus draining through an internal opening at dentate line. External pressure into these abscesses results in pus drainage internally at dentate line, which you can visualize. See, here you are seeing this is the abscess cavity. If you press this abscess cavity, pus will drain into this anal, this is the dentate line. So here you can see this is the internal opening. So suppose if the patients are having connections like this, then radial incision for perianal abscess with low fistulous tract like this, radial fistulas, you can expect. In that case, you have to make, this is the abscess cavity. This is supposed to be the fistula, radial fistula. Then you have to make radial incision over this abscess. Suppose this is ischiorectal abscess, the internal fistula will be somewhat curvilinear. So here you have to make a circumferential incision or curvilinear incision over the ischiorectal fossa. If the abscess is bilateral abscess connected in the midline like this. Okay, this is one abscess, this is another abscess, both are connected. Then at least one incision on either side. You have to put at least one here, both are circumferential or circumlinear incision you have to put. Abscess with low anal fistula. Fistula can be demonstrated by Lockhart memory probe with internal opening at dentate line, which you are seeing here. This is a case of perianal fistula, where the fistula is very low anal one, where you can demonstrate the fistula by putting a probe. That is the Lockhart memory probe. You can introduce it through this internal opening. This is the opening in the abscess cavity. Through that you can introduce it, and this will come out through the internal opening in the at the level of the dentate line. So abscess with high anal fistula, suppose if it is ischiorectal abscess, then you can, instead of putting this probe, you have to put a seton through the fistulous tract on a large curved needle. You have to introduce it, and this also will come through at the in the anal canal at the level of dentate line. So after taking it out, then you can tie the seton thread. This is for management of high anal fistula. You can use this one. So what are the complications of this anorectal abscess surgery? Because we are doing IND, accidentally we may injure the external sphincter. This may result in incontinence because of this incision and drainage. This can happen, or if bleeding very occasionally can happen. If it is persistent, that need to be controlled in operation theatre. Wound infection 10% of the patient, fistula formation in 50% of the patient. Those who are having internal connection between these abscess cavities to rectal or anal canal. In some of the patients, they may develop acute retention of urine. Post-op care, daily sitz bath after each bowel movement, daily dressing of the surgical wound, digital rectal exam should be done daily, and then, after discharge and after a week's time to prevent adhesion between the raw area, especially in perianal abscess. Oral analgesic tablets as needed. Mild oral laxative for 1 to 2 weeks post-op. Patients can be mobilized immediately after the surgery. Patient can be given time off from the work for 5 days. So thank you very much for watching this video. If you think that these videos are very useful, kindly share these videos in your social media. Kindly click the bell button also to get notified regarding my latest uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye-bye.